I'm here to talk about psychological treatments for severe mental illness. And I've always been told that what you need to do is to provide pictures for people in terms of their understanding of what the talk is going to be about. So, how does this work? I'm pressing the green one. Okay. So there's going to be a little bit of outrage. There's going to be a bit of scandal. There's going to be some principles and pragmatism, but there's not going to be any alternative facts. Oops, wrong picture. Okay, so the message as well about this talk is that evidence really isn't enough for treatment implementation, and there's always more that we need to know about the psychological mechanisms underlying treatments and about dissemination science about how to implement treatment. And treatment is actually an evolving science, and I'm going to tell you a little bit more about how treatment has evolved over the past few years, some of it with evidence and some without. So, what kinds of treatment should we be providing, and who we should be providing it for? Well, the usual picture is this, so that you're supposed to be providing treatments which are round pegs to fit the person who's the round hole here, and that we want to avoid as much as possible having a square peg in a round hole. But actually people are just not like that. People are much more like this. So there are differences between individuals which mean that we have to tailor treatment to the individual to make sure that the outcomes are the most beneficial. And we need to know how to allocate those treatments. And this is the results of a survey by a charity called Rethink, which represents people with severe mental illness. And what individuals within their survey said they wanted was more independence, living in their own flat, more life skills, so being able to cook and eat when they wanted to. They wanted to have fulfilling relationships, like having a girlfriend, and they wanted to have a little job, some work. And these are really important. People's goals are really important because it costs about 122,000 euros, I think, because I actually did the calculation a little while ago before Brexit. The costs are actually predicted by these sorts of variables, but this one is the most important because people's dissatisfaction with their current level of independence, with their current goal in life, actually predicts the cost of care. So we really need to take those into account when we're devising psychological treatments. So which treatment should we be providing? Well, there's lots of ways in which we can define treatments. You don't need to read any of this, so there's different modes of action, there's different levels of presentation, there's different levels of target time, so before the disorder ever appears, or preventing it, or at the acute or the maintenance phase. But more importantly, the goals of treatment have expanded dramatically and include all of these different kinds of goals. Well, I can't possibly cover everything, so what I'm going to concentrate on is these cognitive therapies which have a reasonable evidence base, and I'll go on to show you about that reasonable evidence base. Okay, so what is the evidence? I thought at this point I would show you what's in the various treatment guidance that there is available in different countries, and then I will just stop here. So these are the treatment guidances across the world. There is one for Italy, but if you look at the ones that have appeared in the last 5 years, which have the most up-to-date evidence, that decreases somewhat. And if you look at what that treatment guidance suggests, this is the sort of thing that it's showing. And in fact, the USA are likely to change quite soon, because yesterday I saw the Healthcare Review, which is the reviewing treatments of schizophrenia in the US for Medicaid and Medicare, and it looks again like there's going to be a change in what they suggest for psychological treatments. But there is some agreement. So the agreements, for instance, are across cognitive behavior therapy. All of the treatment guidance suggests that we should provide cognitive behavior therapy for psychosis. But actually that's still a problem, because there is still some controversy which keeps rearing its head. And in fact, in the review that I saw yesterday, there is still some controversy within that review about whether we should provide cognitive behavior therapy. So I wanted to examine why we have these sorts of differences between the evidence and the likelihood of implementation. So why is that? Is it because of the evidence changes over time, which may be true? Or is it just a trade war that's going on between psychiatry and psychology? So does cognitive behavior therapy work? The evidence. This is a relatively old analysis now, but of a homogeneous group of studies looking at the outcomes for positive symptoms. And here you can see that the diamond is on the right side of the line, and therefore we're happy because there is an effect of cognitive behavior therapy. But that was just the beginning, because then another meta-analysis appeared in 2014 saying that cognitive behavior therapy didn't work. But the effect size in 2008 was 0.37. The effect size in 2014 was 0.33. Now, you'd think, well, there isn't very much difference between the levels of effects in those. However, the interpretation of the effect size and the interpretation of the meta-analyses was very different. But there wasn't just one meta-analysis. There are now, in fact, 7. And just so you don't need to read any of this, you just need to look at the emoticons. So all but one of them showed significant effects of cognitive behavior therapy over another treatment or treatment as usual. So the only one that failed was the one that specifically looked at cognitive behavior therapy for negative symptoms. So it appears that the overwhelming evidence is still for cognitive behavior therapy. But why is there this controversy? Well, one of the reasons is an issue to do with meta-analyses. So one of the difficulties is that meta-analyses can be this washing machine variety, which means that you throw every study which has the words cognitive behavior therapy into the meta-analysis. And that's one of the things that Jahar did in the 2014 meta-analysis. So studies which were aiming to change negative symptoms or hopelessness or other very specific symptoms, but not positive symptoms, actually were thrown into the mix. However, what they measured was the effect on positive symptoms. But also, the other problem with meta-analyses is that they use completely different outcomes because they're aiming at different things. So some people may be having a primary outcome of having an effect on hallucinations. Sometimes it's delusions, sometimes it's total symptoms, sometimes it's negative symptoms, sometimes it's not even just the frequency of hallucinations, but the distress experienced of hallucinations. And yet we're putting all of these into the same mix and producing these problems. So yesterday, John Ioannidis produced a viewpoint article in JAMA Psychiatry, it's now online, which suggests the standards for meta-analyses. And I think this will start to make it much easier for us to examine the evidence for treatments and particularly stop us from spending the last 2.5 years arguing about something which we should never have bothered to argue about, because the evidence base is clearly there for cognitive behavior therapy. But We may also have some alternative facts here. So this is a paper in the British Journal of Psychiatry talking about the difference, what the NICE guidelines. NICE is the National Institute for Health and Care Excellence, and it produces the guidance in the UK for treatments in the NHS. What Mark Taylor said was that only 24% of NICE recommendations were about pharmacological treatments, and that was wrong. And that actually some of the meta-analyses had very small effects for CBT. And that's true. There were some meta-analyses which showed small effects, however, still effects. When you actually look at the guidance, you discover actually that there were more pages allocated to economic evidence. And actually there were 22% of the recommendations, of the 110 recommendations, were for psychological treatment, and 28%, so more, recommendations for antipsychotic treatment. So we're being diverted as well by people feeling annoyed about this whole issue to do with psychological treatments for people with psychosis. But we had the evidence, we had a guideline, it's still the guideline in NICE to provide treatments, cognitive behavior therapy treatments, but the Schizophrenia Commission investigated whether these treatments were actually being provided in practice. It turns out that only 1 in 10 of those who could get a benefit actually had access to this therapy. And that's because cognitive behavior therapy usually requires quite high levels of skill within the psychological community and the psychiatric community. And this takes time to build up, and we still haven't invested in that training. But also, people actually did value the cognitive behavior therapy in addition to medication. And in fact, this is one quote from a service user, that actually it was some clever CBT that really helped them to achieve their goals. So there's not just agreements, there's also disagreements, and that's on cognitive remediation. So I wanted to investigate that as well. It's a 50-year-old problem. So this is something from McGee and Chapman, and in fact you can go back to Kraepelin and Bloiler, but here it's showing that a service user actually noticed that they had cognitive problems. So we have known that there was a cognitive problem. We have also known that people have noticed there is a cognitive problem. We've also got lots of evidence. I mean, there's shed loads of evidence about this particular issue. This is just a study from McCleary showing that not only do people at first episode and chronic patients differ from normal controls, but they hardly differ from each other in terms of having a reduction in the level of cognitive skills. We also know that this is not just a problem that appears at first episode, that there are people that in fact, they're 6 to 18 months behind in their development over time, and there's lots of data on this as well from, for instance, the Dunedin study. But it's not just that, but people with a low IQ and behavioral problems actually are more likely to have a diagnosis of schizophrenia. And that is different from affective psychosis, where only the behavioral problems at an early age actually predict the onset of an affective problem. Cognition also affects cost. You don't need to look at this complicated diagram, just the big line which shows that there is a correlation, and the only significant correlation between cognition and the total health and social care costs. But also, if you change cognition, you also get reductions in the costs of care later on. So we know it's an issue, we know it's related to costs, we know it predicts outcomes, we know it predicts onset. So is there any evidence that a treatment can actually improve it? And this is a meta-analysis of mine showing that actually there is a significant effect. It's about the same level as for CBT, slightly higher than for CBT. This is for cognition, the effects on cognition, but we also know that it improves functioning, but there isn't very much of an effect on symptoms. I think this is one of the reasons why we have a problem with cognitive remediation, and it's because in some spheres it's called brain training, and brain training is a very big marketing issue. So this is a website from Lumosity. This website does not now exist. I just happened to have cut out the picture before it was before this part was taken down. Lumosity had a very aggressive advertising campaign. It's a private company suggesting that brain training really does improve your, improve your cognition. However, beginning of last year, the Federal Trade Commission fined them. They tried to fine them 50 million, but actually discovered they didn't have 50 million, so only charged them 2 million because of their poor advertising standards. So they actually solicited consumer testimonials with prizes. So they gave iPads, they gave round trips to San Francisco, and lifetime Lumosity subscriptions, whatever that would mean for somebody. So one of the problems, I think, is that the psychological treatments have been usurped into the marketplace and sold as brain training. But there's also some negative evidence which has had rather a large effect. So this is from Dwight Dickinson. It was a negative randomized controlled trial, and his conclusion was that the evidence for this treatment approach remains mixed. This is another study appearing a bit later by a group from Spain, also producing a negative treatment effect. And they're a bit more forceful. They say, according to this study, computerized cognitive remediation is not effective in schizophrenia, whereas actually they only did one study. Now, both of these studies were carried out well. The methodological quality was high. It was a randomized controlled trial. They had a control group. So what do we learn from these studies? Because negative studies really do have an importance in deciding about psychological treatments. So first of all, it may be because they had an ineffective therapy. In fact, the Gomar study, the Spanish study, had never tested this therapy on a group of patients. The only tests were in dementia and autism, neither of which worked. So it may be that actually they just had a treatment that didn't work. Dwight Dickinson also, his treatment had not been tested widely before he tested it in a large randomized trial. The other issue was that both studies included older, more chronic patients. So the average age of studies in cognitive remediation is about 35, whereas the average age in both of these two studies was 48. So maybe there's something about treating long-term patients or long-term service users that requires some adjustment in terms of what you're providing. So maybe what we should do is we first of all need to do feasibility and validation studies. And we also need to consider age when validating our treatment sessions. Maybe older people just need more time, and maybe we just need to give them more time to be able to learn the skills that we want them to. So just coming to cognitive remediation and how controversial some of these things are, this is England and Scotland, both in the United Kingdom. In England, there's nice guidance, and cognitive remediation is not included in the guidance. Scotland has its own guidance called the SIGN guidance. In the SIGN guidance, cognitive remediation is included. They use exactly the same evidence, but again, come to different conclusions about whether they should use it. So as you can see, we don't actually, for many reasons, we don't actually have a united kingdom at the moment. Okay, so I just wanted to show you a few of these. You don't have to read them, but there's a randomized trial in 2017, one in 2016, another in 2016, and one in 2015. And what's common amongst them? Well, what's common is that I am an author of every single one of these studies. You don't have to know anything about them except this, which is that 3 out of 4 of them actually were negative studies. And even the one that wasn't negative was a little bit negative. And what I wanted to say was that actually, even if we get negative studies, they're still important. So we still need to keep doing these randomized trials because they'll tell us what not to do as well as what we can do. And maybe the only lesson learned is perhaps you shouldn't include me as an author on anything. Okay, so where are we going to now for the cognitive therapies? So boosting outcomes is the first thing. So in cognitive behavior therapy, you can boost the outcome by adding it to other treatments. And this is assertive outreach. It's a study by David Fowler showing that overall there wasn't an effect for a mixed batch of people with severe mental illness, but actually for non-affective psychosis, for schizophrenia, there was a benefit for symptoms and a benefit for constructive activity. In cognitive remediation, this is a study by Chris Bowie. He showed that if you provide cognitive remediation on its own, it improves cognition. If you provide skills training, it really doesn't have an awful lot of an effect. But if you provide both cognitive remediation and skills training, you not only get the cognitive boost, but you also get a big boost in the work skills and community functioning. But perhaps this is the most important for boosting outcomes. This is a cognitive remediation added to supportive employment. These are the people who are randomized were randomized because they had failed in a supportive employment program. As you can see from the orange lines here, that when you add cognitive remediation to the supported employment, then you get a boost for the amount of time that people work and the likelihood of them being in competitive employment. This is really important because it helps prevent failure and saves money because you're not actually putting people into a program where they will actually not succeed. Tailoring therapy. So if we want to tailor treatment, in terms of cognitive behavior therapy, that's mainly been through defining the target that you want to aim at. So this is compliance with command hallucinations, a very large randomized controlled trial. Luckily, this was positive, and I was an author of this study. I did carry it out with Max Birchwood. It halves the compliance rates at 18 months, which is really important because these are command hallucinations which were very dangerous. They were ones which said, go and hurt somebody or hurt yourself. And this is slightly different. This is about how we should be tailoring treatment. So this is 2 years after a cognitive remediation study with supported employment, showing no effect, except if you divided people up on the level of functioning at the beginning of the study, actually there was a significant result in the end. That means that in order to save money on cognitive remediation provision, we would choose the people who were the lowest functioning to get this boost in outcome. But I also wanted to talk about interventionist causal approaches to try to work out how treatments work so that we can boost outcomes in the future. So this is what it would look like. So you would look at particular therapies which would change different aspects of a sort of mediating variable on the potential for delusions. And I'm going to show you 2 studies which look at this. They're both by Daniel Freeman, who's at Oxford. This first one is about worry treatment. So he found an improvement in worry following his cognitive behavior therapy aimed at worry. He also got an improvement in delusions. But most interestingly, when you look at what predicts the effect on delusions, 66% of that effect was mediated by the effects on worry. So there is a relationship there. But, and this is the opposite of this is a study looking at the effect of treatment on the effects of sleep. He found a very significant effect on insomnia However, he had no effect on delusions. So these two are not related. Sleep and delusions were not related. This is a lot of different factors which you don't need to go through. Some of them, particularly the genes ones, have been found in Italy. They're things which we know relate to outcome. But if we looked at a model of therapy, and just a few of these variables, not many, so therapy could have an effect on boosting cognition. It could have an effect on functioning directly. It could affect the relationship between cognition and outcome. It could affect your coping skills, and it could affect your motivation. And not one of these models is mutually exclusive. So this isn't a short-term set of experiments that we need to do, because it is very complex. However, the doctor's database, which is now an NIMH-hosted database, is keeping all of the individual data from randomized controlled trials of cognitive remediation, which means that we're now going to be able to do more network meta-analyses to look at these specific factors across studies rather than just within us doing a meta-analysis. So are they all the same, these cognitive therapies? Maybe they're all acting through the same process. And certainly Jerome Frank thought this. He thought that the main aim of any psychotherapy was to combat demoralization. And he thought that they shared features and that they had certain effects in common. So how would we rebut that? Well, what we need is a head-to-head comparison. This is one of those head-to-head comparisons, excluding all the studies which might be at have a high risk of bias. And what you can see is there are differences between different therapies in terms of their outcomes. And if you look at specific symptoms, they haven't done it on functioning outcomes, but if you look at specific symptoms, you can see that actually social skills has an effect on negative symptoms, and cognitive behavior therapy has an effect on positive symptoms. So there are differences between individual therapies in terms of what you want as an outcome. So coming on to the new wave treatments. So this is the section on new wave treatments, and I'm just learning animation in PowerPoint, so you get a bit of a wave. The first sets of treatments actually include a therapist, but they are blended therapies. So they include a therapy, but they're blended with e-therapy. So the first one I want to describe is avatar therapy. This is where the service user actually builds up an avatar of what the voice would look like and what it would sound like. And this is a trialogue, so it has the service user, the therapist, and the avatar, and the therapist speaks to the service user as a therapist, but also speaks through the avatar. And the idea is to increase power and control over the avatar, and the avatar actually changes to be nicer to you as you build that power and control. And I'm going to show you something completely hot off the press, so please don't take any photos of this, as Tom Craig, who's carried out the randomized controlled trial, allowed me a quick look at this data 2 days ago. This is a big randomized controlled trial comparing 75 people in avatar therapy with supportive counseling. And he showed generally an overall positive outcome, at least at 12 months after a very short 7-session therapy. He shows improvements in the frequency of voices and improvements in the distress of voices, which are clearly really important. What they have to do now is to look more deeply into these results, to look at who is improving, and maybe there are some other mediators and moderators of outcome. There's also, of course, virtual reality cognitive therapy. So you can produce we often give people in cognitive behavior therapy practice, homework, But it's very difficult for them to do homework because it's very difficult for us to have control over the environments that they're going to be in. But with virtual reality, you can do that in the clinic. And there's therapies that have been started on using traveling and using bars to look at social issues. And you can actually adjust how much social stress there is by getting people to look at you and measure the effects on people with a diagnosis of schizophrenia, but also do the cognitive behavior therapy in situ. And this is becoming more reasonable. It used to cost an enormous amount of money to do cognitive behavior therapy with virtual reality. Now you can get a cardboard box which you just slip your iPhone into, and that will produce a virtual reality. So you can do this at home as well as in the clinic. There's other therapies that are blended. So this is one where Thinking Well and Slow-Mo, which actually has 8 therapist-supported sessions with it, which uses a computer. And then between sessions, there's an app which supports you, so it actually gives you the homework on the go in a mobile way. And studies by Philippa Garrity and her group have shown that you do get improvement with paranoia and reasoning with this therapy, and there's a lot of evidence to show now in a different study that actually it's feasible to carry out and acceptable to service users. Acceptability is vital for doing this sort of work. She's now doing a very large randomized controlled trial, which is going to start in about 2 weeks, I think. But also we have computerized cognitive remediation, which will allow people to do sessions at home as well as in the clinic. Meta-analyses have shown that these do work for social cognition and employment, but there's a new therapy which is really concentrating on metacognition rather than just specifically on cognition. And this defines cognition as metacognitive regulation and metacognitive knowledge, and actually uses those areas to try and involve cognition in that. So what we do, and this is my therapy, so I own up to it here. So what you do is to target cognition. You get people before they even start a task to think about how they're going to approach the task. So they think about how long it's going to take, how difficult it's going to be, and they choose strategies for doing the task. We then get them to use the strategies. This is producing a text message, and here they're using highlighting, which is one of the strategies, to be able to identify what information they need to send on their phone. So these are also very ecologically valid type of tasks as well. At the end of the therapy, we ask people to, again, think about how difficult it was to do the task. And we get them to compare how long they thought it was going to be with how long it's actually going to be. And we get them to reflect on the strategies to discover which are the ones that they think helped and which are the ones didn't help. So again, engaging their metacognition. And this is a couple of results from a study that's under review. So we get changes in visual memory, and we also get changes in structured activity in a similar way to the way that David Fowler measured structured activity in his study. So this is the evidence for mindfulness, and I usually stop here and put this blank screen up, but actually towards the end of last year, there was, and I'm introducing this in a mindful way, there was a study. However, it was negative. So there still is no evidence for mindfulness in treatments for people with severe mental illness. Now, I was going to go over this very quickly. If you change the outside of people, of course, you are going to change the way their brain processes information. So there's evidence for both cognitive behavior therapy and for cognitive remediation. But what I want to show you is I think, more important, and that's that cognitive remediation actually seems to prevent grey matter deterioration in people at first episode. And it seems to me that is one of the most important reasons why we should be doing this form of therapy, because it might prevent longer-term damage that, to these individuals. But I'm coming sort of towards the end. So we need large-scale rollout, so moving to mobile. Lots of reviews suggesting that it is promising, but actually there's really little data on acceptability. Most people want a therapist as well. There aren't many randomized trials, and they're all very short. And there's a risk of digital exclusion, and we've just published a paper about a month ago showing that even today, there is digital exclusion of people with a severe mental health problem. And that is a real problem when you're trying to introduce mobile health. But it has been introduced, so this is ClinTouch from Manchester. So the phone beeps, the person responds, and it's asking about various symptoms and how you're feeling. You get feedback from the phone, and the clinical team also gets notified if these problems reach a particular threshold. And if they reach a threshold and it beeps and says red alert, then the mental health team will actually initiate a contact with the service user. Now, there's evidence of all of these things: safety, acceptability, validity, and efficacy. There's also a large randomized controlled trial where the primary outcome was PANS, and this is one that I took part in. So there was no effect overall, but there was an interaction, which is really interesting. So in the first episode center, which was my center, there was a benefit for using the ClinTouch for the PANS total, which is the main outcome. However, in the community team in Manchester, there was only an effect on positive symptoms. But as you can see, the ages differ radically. So I was dealing with people whose average age was 26, whereas the people in the community team, the average age was 46. And maybe this is also another issue where age may moderate the effects of these mobile health interventions. So is it all over? We don't have any evidence to exclude anybody. Even when there's a difference in age, that doesn't mean to say there isn't improvement, just that the improvements are smaller. In terms of what we should provide, 2 treatments seem better than 1 at the moment, so adding psychological treatment to other treatments boosts the effects of both. This is my view. In my opinion, the earlier the better. You saw the cognitive remediation for people at first episode actually prevented the deterioration of grey matter, so that's important. But we really need another question, which is how do we provide them in normal clinical care? And that requires dissemination science. So there is some dissemination science on psychological treatments. That's the NAVIGATE program in the RAISE study, which was carried out in first episode services in the USA. And they showed that with their treatment, people stayed in treatment for longer, which is obviously a good thing. And importantly, the quality of life actually improved in those people receiving the NAVIGATE program. They are thinking about ways in which they can separate out the components of care to see which one was the best ingredient, but I expect that will take another 4 years to do. So the message is that evidence for benefit doesn't produce implementation, doesn't even produce agreement about what should be implemented. We need to use new approaches to detecting the important ingredients for treatments and about how they work, and psychological models. And that psychological treatment is now moving towards more blended care because e-health and mobile health does offer us a bonus. But we just got to keep in mind a few things. So one of them is that schizophrenia is complex. There are lots of different symptoms which are important or not to each individual. And if you can remember that these are the sorts of things which the Rethink survey produced as issues which that were important to different individuals. And I just wanted to show you Christine and John. So Christine is young. She's just had her first episode. She really doesn't get on with her parents. She's not at all keen on swallowing any medication. She's got a whole group of friends, so she has a social network. John, on the other hand, is in his 30s. He doesn't have a Facebook account. He doesn't have any friends. The only contact he has is his sister, who comes every 3 months. He stays mostly in his room. He takes medication, he has a depot, and he doesn't mind. Now, these two people will have completely different goals, and because of their different goals, they will have completely different psychological treatment profiles. So Christine probably would benefit from family therapy and probably some cognitive behavior therapy, whereas John, because his social cognition is pretty poor, he would need maybe some social cognition and social skills training, and maybe even some cognitive remediation so that he can concentrate more and something to get him out of his room. So, and I am really on the last leg now. So in terms of outrage, well, we do have ample evidence, but we still have many disagreements on how that evidence should be used. In terms of scandal, we don't actually need scandal. We just need to blend psychological and psychiatric treatment with technologies for the best outcomes. So let's not carry on having arguments about it. Let's just move forward. We don't, if we take an interventionist causal approach, which identifies the best treatment ingredients, we will have facts and not alternative facts. And finally, we really need to listen to our service users about the goals to guide treatment, because they're the most important people and it's the only way to implement treatment.